Yeah. Deneme 1 2 3, deneme 1 2 3. Deneme 1 2 3, deneme 1 2 3. Thank you to all of those who's been filling this place for so long until this time. We're going to talk about ophthalmology, laryngology. We'll listen to the stem cell conference. Ayşegül Hakkın. Yeah, you're just asking her to keep it a little shorter because some time has already been spent in the previous one. I'd like to start saying good evening. I know it's a little late hour. I wouldn't like to go too much into the issue and just, going over it rather superficially. I'd like to talk about the experimental studies that we made on the stem cell. We've been working on this for a couple of years now. And I've been adding what we've been doing every year, every year. The most commonly discussed issue is the bone tissue tracheal transplantation. This is the subject that we are focusing on the most, because this is one of those areas where treatment is difficult. Tracheal in childhood is because it's lost in the adults. So if it's lost in the adults, they will have to breathe from their nose, like from a hole. So either they will have a tracheal transplantation, so you will have to have suppressive treatment all the time throughout your life. The Lancet publications told about the tissue transplantation in tracheal. There's a lot of research made on this subject, and we've also started working on it. As we've been telling in this presentations today, we need origin, niche, and stem cell. If you're talking about the tracheal, what can we use? We can use biomaterials, 3D printer materials, nanotechnology materials, or as we use human cadaver tracheal desalination. Yeah. Now, in the literature, the bone tissue tracheal transplantation, I would like to show you these people that we found on the literature. One of the first ones is the one in Lancet. There's a laryngomalacia and tuberculosis. They've produced tracheals, they've transplanted it, and this is one of the living patients. Its 5-year results have been published. Tracheal, around the tracheal, they are not really a problem. It's 3 years. Treated because of some problems in the tracheal area. It's all bone engineering tracheals that we are talking about here. And this baby was lost after the operation. And another patient, the bronchia, because of he was transplanted because of bronchia, and this patient was also lost. Another reason, this child is where bone. This patient is living. The bone marrow origins stem cells have been injected in vivo, waited for the differentiation into other cells. What is the essential principle? we take the cadaver and make it acellular with detergents and decellularize it. And then we take the bone marrow from the recipient and the fat tissue, adipose, and we plant it on top of that. And then for the recipient, we take a piece, this piece, which it can consider like its own piece, is a tracheal, and it's planted into the patient. The animal experiment, we took the rabbit's fat tissue stem cells, loaded tracheals were transplanted. The critical length is half of it. It was removed. The fat tissue decellularized tracheal was overlaid, anastomized. This animal experiment video. After the tracheal of his own were taken out, this piece that we see here, stem cell loaded tracheals, were inserted, anastomized. Anastomosis were made. And then these animals were radiologically and macroscopic and microscopically examined. And as you can see here, the new tracheal, the neotracheal, the own tracheal of the animal has been integrated, so in the MR scans. And macroscopically, the transition area, the own trachea of the patient, as you can see, the transition area is visible, but it's completely integrated. The same thing can be seen under the microscope, the tracheal of the rabbit and the new tracheal. Microscopically, this cellularized tracheal in bone tissue engineering, the goblet cells and the cartilage cells are observed to emerge. The Q tracers were marked on the bones, in the epithelial stroma and in the cartilage tissue. The stem cells were marked and followed, tracked. What happened later? In the 3rd month, the rabbits in the tracheals, there was like fibrosis and shrinking. And if we pay attention to that, the new tracheal had a shrinking and disformation. This study, it was published in one of the stem cell magazines. We later thought about how we can overcome these problems, and the decellularization method has been changed. We've thought about that, and the human tracheals, with the new method that we applied, were decellularized. In this, what we do is the normally used detergent enzymatic decellularization method is the chemical method. Instead, in order to reduce the chemicals, we used fibrillation or something like that. In the chemical and physical methods were combined, and the results are pretty new. These pictures were taken last week, and I got them last week. And these scanning microscopy results, detergent enzymes, so the epithelial tissue has been totally removed, that we can see also below. The cartilages were empty, there were holes where there were supposed to be cells, and the stroma is decellularized. It was observed, and light microscopy has been confirmed. Our study continues. The PCR will be made, and then this cellularized matrix will be loaded with stem cells, and then it will be decellularized. There will be stretching tests between the two. Like, is there a difference between the strength of the materials? So it will be tested. We will not directly implant it into a human being, of course. We will first try it on pig trachea. Right now, we are loading stem cells And after completing the pig trials, I hope we'll be able to present you the human in vivo transplantations from here. By the way, the whole world is scaffolding the 3D. They're focusing on the 3D printing, and we didn't want to disregard that. So the Petrolab, they had 3D printing designs. These are the scaffolds that we're going to obtain through the 3D printer. With the experiments, we're going to try to examine these new materials. This is a team. Another study is, actually this is not, this is finished and published. As yesterday Mr. Sardar told, neurogenesis is continuing. Now our medical faculty semester today, we know that the regenesis continues and goes until the olfactory bulb, and we get the olfactory area through endoscopy and get neuronal stem cells, and this is the only neuronal stem cell that we can obtain from human beings. This is the hippocampal lesion. Well, the successful results from the animals, this was like, this came to our mind after this revealed study. We got the stem cells from the origin of olfactory, and we tried them. We presented an experiment. We made an experiment. We've cut down the facial nerve, and we call it a conduit. We've placed that material, conduit. It's like an empty pipe, and we've placed the cut-off nerve ends into this material. And the first group, he didn't put anything, and into the medium line, and the PVC in the second group, and olfactory originated stem cells on the third group. And then after the two weekly EVGs, we observed whether it's repaired. Well, without using anything, we can obtain anastomosis, so there's a recuperation. But the green line here is the stem cell group. This group is recuperating much faster, recovering much faster. GMDI marker were used to track these cells. The third group, the lotus stem cells changed into Schmann cells, which provides myelinization and transition. The stem cells turned into the Schwann cells, and this was published in the most prestigious magazine of laryngology, Ophthalmolaryngology. And this large team is the team of that large study. And another study has started just now, recently. It's in the setup stage. The problem with the ear cap is gone or anomalous. So it's a part of the birth defects and something that we encounter frequently. And there are a lot of studies on this. Somehow to reconstruct these things are tried by the plastic surgeons, but it's not always giving the best results. For that reason, we've also tried to see what we can do in this area, and we've got the scaffold from the 3D printer, and on top of that, we've used the cartilage from the ear of the codis. We culturated them and planted them, and this study is ongoing. First of all, we were planning a larger R&D, but we've changed it to be able to make it fit the animal that we're going to use, and now at this stage it's going to be loaded into the animals. This is the theme of this study. Now, laryngology is sensory neural loss of hearing, and about this there are also experiments. The effects of these sensory neural loss of hearing is based on inner like inside the ear there's like a problem and with the neurons, so it's either inborn, innate, or later on. We cannot fix them, but we make implants and hearing devices. But we thought about using stem cell, and in this area there are some research in this area. It's not very successful. It cannot be said that it's very successful, but the inner ear is a little bit anatomically deep. It's not easy to access. We've tried to implant. That's what we questioned. Can we give stem cells peri-lymph node, peri-lymph area? So how can we access that area? We thought, and anatomically, and the lymphatic pouch, we thought, and we got this material that can be found in the guinea pigs. We've tried to reach that area. It demonstrated that we reached that area. And in the upcoming study, we're going to use a neuronal stem cell of the olfactory origin and see what kind of results we can get in this. And this is the team that is proceeding with the studies. So finally, although it looks tiny, but there's a disease that changes life quality of a person, the sound cords of the epithel. So it's like the sticking of these vocal cords to some area. This causes vocal distortion, especially in the males. It's like a thin sound, and it's usually inborn, like from the birth, and it changes the psychology for the negative in the youth and later on. We use surgical or with some injections, but with the study modalities that we have been conducting, it's not successful. The conventional methods are not very successful. So can we use the mesenchymal cell in this area? We've tried to come up with an animal experiment, but the literature, there was no, there was nothing of the sort in the literature. So we've started from the nothing. We've created an animal model. Of course, this is very highly difficult. This is the larynx of the animal, and it's 1/5 of that. So normally in the human vocal cord, it's difficult to access human vocal cords even. So think about that, like 5 times multiplied, it's 5 times more difficult. So we've been working on establishing this animal model for 1 year, and we got this endoscopy as you've seen in the picture. This is microscopically shown, and in the same manner you can see sulcus structure here. In the next month we are going to be presenting this in London. So after establishing this animal model, we've given the stem cell. We got 3 groups. The first group is injected with a stem cell. The second group is normally, as always, hyaluronic acid. And the third group, we haven't done anything, the control group. The first group, we got new cells here, as you can see in this area. And in the light spectroscopy, in the microscope, these new cells are pre-muscular cells. And they were marked. They have to be marked and proved in the fluorescent microscope. It couldn't get those images. He said as a pre-information that they are tracked, they are marked. But those photos we don't have yet, because we also wanted to look at with the confocal microscope, and the result will be left to the next year. But in the coming days, we'll get the results. The other group is hyaluronic acids, the normal method that we use in humans. It created some foreign particles, and in the control group we've done nothing. And the sulcus vocalis continues, and then there's fibrosis and endometrial tissue. As you can see, it's a teamwork, and in our last work, laryngology, there are a lot of studies in this area, and I hope you're going to be doing this with us, or we're going to be doing this with you from the 5th year. They're very excited, they're very eager. We're starting some studies with them, and if you want, you can always come. Our doors are open. And I've mentioned it in the entrance speech. The stem cell and the regenerative medicine is the modality of treatment in the future. I don't know if it's going to be so prevalent and widespread, but it's going to be the treatment of the future. One question, if you want. One of the first who founded this İÜKÖK student club and is in the optics in Istanbul University optics department, ophthalmology. I'm not sure. Yeah, no need for introduction. I'd like to thank the dear students and professors and colleagues for inviting me here and this opportunity to speak after so many years and 1 minute. Let's go back. Does that work? Cornea, limbus. Stem cells in the eye disorders. Burak Mergen. So we started with a lot of excitement in 2011. It's been 7 years in 2018 now as an assistant here, being a presenter here. It's a great honor. And in the first stage, this exciting journey, I thought it was going to come to an end. There was a fear, but now it's going much better and much larger and much more passionately into that direction. That's a great source of happiness and honor and pride for us. Applause. That's why I'd like to thank my dear friends who've organized this meeting and working here with excitement in here until the last hour, and all the students. Another fear that I had was that the administration could somehow disintegrate, and that was one of my fears. That's now, with the help of powerful women under their dominance, it's going very well. I celebrate them, and I'd like to start. So, as an assistant in our department field, I finished 2 years and reached kind of a maturity a little bit. And I'm excited to start studying, and the reason I chose that is because I wanted to try stem cells. I'm going to talk about that as well. Of course, it's early for having highly experimental studies, but even doing these small studies are very difficult. So trying the experimental studies are, well, I couldn't find that environment and energy yet. But I hope we will be able to make that in these years. In 2012, we had this congress. It was international as well, and we had a vision, and we had students from international students and international speakers. And Frank is still here. Frank was there too, and these people from the first congress, I had also brought. So they're in good places now, and being here is actually a great beginning. You'll feel the privilege of that. What am I going to talk about? It's the last speech. Everyone is giving their last gasps and breaths. And the eye anatomy, I'll start. And they always ask in the eye. It's like, because, we are in the health sector, it's like in the inherited diseases and eye diseases, can you apply stem cells? Is it solved? Or some aunts and old people come and ask us, they probably don't know. You are young, you probably know. So what happened with the stem cell? It's like, what's up? So there are some people like that asking me questions. So as an answer to those, I'd like to say that some people are maybe specialized or not, or what are the origins of cell in the eye, for the eye. So you probably have seen what it's like. It's a front and a back and a retina and a cornea, and there are like stem cells resources here in the limbal sources, and then there's the retina pepita cells, and then there are other cells that are told to be stem cell properties, but they're not sources of application. So we're going to talk about limbal ones and epithelamius. I couldn't hear that one, I'm sorry. So that explains why I chose to do my studies on this. If you want to work on the eye, it's got an immune privilege feature. So it's got lower, it's because it's like the cornea barrier, there's an immunity, so you can see under a microscope, you don't have to do anything, you see the results. There are two eyes, so it presents a natural control group. One side is like when you apply something on the one side, you can check it on the other side, on like a control group. So it's you can also reach tissue non-aggressively. So the cornea, let's start from the front. There is a limbal or rimbal stem cell exactly there on that circle. I'm going to show where it's on the cornea as well. You see that arrow on the eye, that's the limbus. In the limbus, there are stem cells, they replicate and regenerate. Walked paralysats. Where do we use that? Sometimes they throw acid on the eyes, sometimes a foreign, like maybe a work problem, acid or something. Limbal stem cells, they seem like they don't have much, but we tell them this eye is going away, and we're telling them. So the limbal cells are damaged, and conjunctival cornea is that it prevents it to advance to that level. So the corneas are becoming vascularized and little, so they lose sight. So what do? We get the limbal stem cell transplantation. That's what we do actively. There are different types. It's not very important, but what is important is to use this technique effectively and successfully. The limbal cells have to be replicated at some point, and the anoetic membrane can be done, like anoetic membrane can be placed on the eye and made it on in vivo or ex vivo, so in vitro. So you can replicate it right on top of the eye. So you can transplant. You can get it from the other eye and put it on the diseased eye, little by little, piece by piece. You can spread it over the eye. Now, in these kind of applications, the conjunctival limbal autograft, we get the limbal cells. It's one of our cases. During these limbal cells, the cornea is renewed. So if a little tissue is left, the catoplasty, we remedy that. If you don't do that, the cornea transplantation will not last. And cultured either ex vivo, in vitro or in vivo, amniotic membrane. So putting the limbal stem cells on top of that. Even if it's not perfect cells, it's like healed results, pre-op, post-op. We've had a recent case. There's a tissue, and placing it on the limbal. It looks. I'm not sure if it looks good or not, but if you can get 50-60% seeing if that site is revealed. 6 or 10 vision. Sometimes it's congenital. from birth, and well, we can make these clear corneae after the transplant. Sometimes pterygium. Sometimes the first thing that's done is the cutting, and so there's a huge risk, 60-70% risk. So the researchers have come up with, it's about the communication problem around the area. So let's put limbus stem cells here and decrease the autography, pterygium, surgical operation. We are conducting those things, and after that the patients get recovered. In our clinic, the last thing that I've mentioned is simple epithemal transplantation. In that method, there are like little limbal cells, little by little, and after excising putting it on the amniotic membrane, and by doing so, we've got like 1 year results on over 20 patients, and no damage, no failure yet. So when it's actually showing that there's a communication problem there, and it must be placed there. So it's like it's got successful results. And like, you know, roughly we've skipped the frontal side, so limbal stem cells somehow is replicated in the culture, and it's gonna give better results of treatment. So now let's come to the retina. That's what most people wonder about, and the hard to treat part is here. The retina needs to cannot have a regeneration, healthy regeneration. So it looks very complicated here, but like they talk about 10 layers, and the retinal pigment epithely, there's like a damage there, and somehow it's not possible to regenerate, and they get progressive loss of seeing. One of those, so the yellow spot disease, age-based macular disease, abnormal vascularization, and they get some damage on the area, and then it's irreversible. What we do is, in order to prevent vascularization, we put injections with a needle in growth factors. So we inject growth factors. That's what we do. You know, there's no other treatment, and in regenerative medicine is a great need, and that's why a lot of patients come and ask about this. You can see the healthy tissue, and you can see the damaged tissue below. What we need to do is to place cells there. That's all, but of course it's not so simple. It looks simple, but yeah, it's not so simple. So even if you place the limbus on the long term, what kind of success it's going to have, these are not clear yet. And where are you going to get it? Are you going to get it from someone else? What about the retina pigment of the other person? And it's going to create problems for them. So where do you get it from? Getting like patches from upper areas or corner areas, but those are like very low success rates surgeries, and requires a lot of surgical tact and skill. And science wants to reach injection ideally, and like, yeah, without getting immunoreactions and getting injections in that area. There are a lot of studies. They talked about IPS before. There are researches on IPS as well, authentic research. And reliability and validity research is done first in clinical research. Are these cells going to give oncological? Are they able to differentiate into any cell? So are they going to show an oncogenic feature? So these are questions. We got some results. It's usually all about that it's reliable. It's basically these work to that end. Subretinal area. That's the defective area. As I said, the results are not about any tumorigenic reactions so far in 1 year. Other than that, there are studies from Korea, IPS-based studies. Yamanaka team, Takahashi has been taking it over. The retina pigment layer differentiating it from iPS cells. So there are a lot of sensational news about the stem cell in the media. So there were a lot of news about them as well. Getting iPS from tissue and then differentiating it into retinal pigment and then give it to 2 patients. And when observing an oncogenic reaction, they stopped that study, paused that study, but they restarted it and they also accumulated the results. But the foundational problem is the iPS is you get the iPS from the patient and you differentiate it from the retinal pigment. It seems easy, but that takes like 11 months and $930,000 for one patient. So for someone will definitely want to endure it, this price for someone who's got the money, but this is like $1 million for one patient. That's if you gonna give this much price, you gotta give them 100% sight. So creating a bank from iPS cells, that's what they're trying to do. It's like the umbilical cord bank or the bone marrow bank, trying to create these banks, and by doing so, getting iPS cells from another patient, you can use those in 1 month and get it low cost efficient. So, as I mentioned, the degeneration studies, macular degeneration studies have been obtained from the studies. Like the results have been obtained. They haven't seen a rise in their seeing, but I missed that part. Embryonic stem cell studies. From a visual perspective, it might not mean a lot, but here we're talking about a significant rise in the sight. So they tried on 10 students, but the Nature magazine has published those 2 results. And 29 and 21 letter, more letters they could discover. So this is like a very hopeful treatment in a 1-year study. So next to all of these studies, this is very open to abuse. This field is very open to abuse. The adipose tissues, the stem cells, are not so tumorigenically problematic to create tumors. But when you put them in the eye, there are significant complications. And without any permission, if there is no permission, they can cause significant complications. The Journal of Medicine published in a study, in a totally profit study. They got them $5,000 in a clinical study from 3 patients and injected, stem cell injected, under the banner. And they go to the same clinic and they get different problems. Retinocomory, retinal occlusion, and they need to get surgery, and they lose their sight, and there are problems. They collected them and published it in a magazine. Even though they are very hopeful, they gotta be careful with these, precautionary. So we talk about cornea and retina, and finally, iPS cells, perhaps mentioned, but modeling, disease modeling through iPS. So after obtaining the iPS in a lab in the US, they said they come up with the idea of using this for disease modeling. they're turned into cells like these. How can we use it for modeling? You can get the IPS of someone with the disease and get someone normal without disease, and then, well, you cannot biopsy. Well, it's not possible to get the biopsy for the get the pigments. So you get the IPS, you get to compare both. So get to compare the diseased cell group and get them in a petri dish and model them and change the mutation phenotype. Try drugs to see if it works. And there are a lot of things like these. Let me talk about genetic modification. After changing the mutation, they changed it into photoreceptors. Endoplasmic apoptosis is more. So when they use drugs and recover it, can we intravenously apply the drugs to get them to stop losing cells? That's an idea. So these are the modeled diseases. So there are a lot of clinical studies about stem cell, all types of mesenchymal, umbilical, pubical, yeah. So to prevent cell loss or to reform the disrupted area. There are 2 publications in our country. These are very difficult tasks. So get the permissions, clinical permissions. It's very difficult in the eye diseases because the stem cell generally is ethically very controversial, and people, it's usually not permitted from the ethical perspective. So you got to start with the animals. Well, it's difficult in these processes to study animals in this process. After specialty, perhaps I could do that. As a result, the cornea, the limbal stem cell, the culture is going to be more successful, of course, in the petri dish. We can get drugs. We can get. We are very close to getting good results. I mean, we are close to getting some results, and the profit-based in China, there are like no sensational news in Turkey, but especially in the Asia, Far East, and China, there are lots of stem cells applications. Got to be careful with those. And in the last week, there was, you probably have seen it a lot, and our motivation has really been decreased because of this event. We are trying something to create something scientific, and we are spending so much effort. And all this accumulation of knowledge is being taken away from us. We are in a process. Today, the Prime Minister's explanations were in the same direction to confirm this. And before I finish my conversation, I would like to say that we shouldn't be fractured, and thank you for listening to me. Our universities shouldn't be fractured, said. Should we get some questions or? Okay, finished. Thank you. Giving certificates from the foundation that supported them to give Professor Carlton and so on. So the certificate ceremonies. Sempozyumumuz bitti. Dikkatiniz için teşekkür ederiz. Sosyal medyalarda bizi takip edin. Sizi tekrar görmek istiyoruz bir dahaki sefere.